Good afternoon, I'm Alison Paulin, and I'll be talking to you today about augmentative and alternative communication in New Zealand intensive care units. I'll be presenting a small portion of my qualitative research project, focusing on experiences of healthcare professionals. I'm aware that not everyone in the audience might know what AAC is, so I plan on going through a case study to illustrate what this is and the potential that it has. I'll also briefly just talk a little about what I found about this the current state of communication in intensive care units in New Zealand, in ICUs. This is communication between healthcare professionals and patients. Specifically, we'll be looking at the limited alternative communication that's being used, and also the limited use of alternative access modes, and I'll talk a bit about what that is. If we have time, I'll touch on the perceived barriers to effective communication. So our case will be Steve, who comes into Middlemore Hospital, 25 years old, a contractor. He comes in following a complete C4 fracture. He has difficulty breathing independently. They give him a tracheostomy and put him on a ventilator. He just regains consciousness after being transferred from surgery back to ICU. At that stage, he has no movement in any limb. When he wakes, he tries to speak but becomes tearful when no sound comes out. The nurse looking after him can't figure out what he's trying to say by just lip reading, so she reassures him and tries to explain what has happened. The nurse checks if Steve can nod and shake his head, but he's not able to do this reliably. She notices he raises his eyebrows sometimes and is able to do it when asked. So she suggests that he raises his eyebrows when he wants to say yes. They practice this a bit, and she documents it in his notes and in her handover. Now, usual care for Steve may mean that the next day is pretty similar to the day before, communication-wise. When he becomes tearful and seems to be wanting to say something, the nurse reassures him, describes what has happened, asks him some yes-no questions regarding his care. Do you have pain? Do you need to move? Are you itchy? In response to this, Steve closes his eyes and refuses to open them for the rest of the shift. Let's look at what could have happened, how things could be different if some alternative communication intervention was used. Let's say Steve is tearful again, attempting to communicate. The nurse finds a communication chart. One side has just basic needs, one side has an alphabet chart. She asks, do you want to say something? His eyebrows shoot up. Is it on this chart? He asks, the basic needs chart. His eyes close. It's never on the chart. She flips the chart over. Want to try spelling, she asks. Eyes shoot up. So this is the alphabet board that they use. Because Steve can't point, she has to provide alternative access. It's called partner-assisted scanning. It's too slow to go all the way through the alphabet, one letter at a time, every letter that you do. So first of all, she scans for rows and then for columns. I'm just going to show you a brief video of someone with motor neurone disease using this method. We haven't got any sound. So he's confirming. And when you see it in real time, you find that it takes 15 seconds for the patient to communicate a healthcare need that he is needing. Obviously, they didn't need the letterboard anymore because they're both very, very familiar with it. So they just remember it in their head. So this tells you, this case study and video tells you a little bit about the importance of communication for reducing patient stress. Obviously, ability to communicate novel messages is really particularly important for this. Also, patients can become involved in important decisions about their own medical care when they're cognitively able to do that. However, it's not just a nice to have. The Joint Commission found that communication is the leading cause of adverse events in hospitals, and the inability to communicate in a Canadian study caused a 3-fold increase in risk of adverse events for hospitalised patients. So if we move quickly on to some of the findings, I don't have time to describe the study, but I thought that a few little pinpoints from the findings might be helpful here. I found very limited AAC used in intensive care units in the 5 DHBs that we had participants from. We used lots of yes/no, facial expressions, gesture, lip reading. There was occasionally people breaking out the pen and paper, but not very often was that successful. And this is leading to some communication breakdowns and certainly limited communication opportunities for patients. This is very similar to international findings. And to just touch briefly on the biggest barriers that the nurses and speech language therapists in the study reported, overarching, although some of these ones lower down in the chart there were mentioned, the biggest barrier, as you might imagine, is perceived as time. Specifically that life-preserving treatment takes precedence over communication interventions. One of the participants, interestingly, had a different perspective. She strongly felt that time was a facilitator of effective communication and in fact of a good positive working relationship with her patients. It's almost like if you use time to develop effective communication with your patient, you can have a more health-giving role. And this linked closely with a little bit of the literature that I read about time. One article explored the meaning of time for ICU nurses and also found a correlation between the perceptions of time, your attitude to time, and the likelihood that the nurse would try aided communication tools. It's something I continue to reflect on when I have time in my own practice. You know, how does my attitude to time influence my practice? Do I see time as friend or foe? And what does that then mean that I do in the choices that I make and how it impacts on my patients? So it feels like there's still a lot more to learn. How do we help patients communicate with us when they can't speak? How to help communication partners learn to provide appropriate supports in what are often very difficult times. But it's clear that there's great potential for augmentative and alternative communication tools and strategies to add value with our non-speaking patients, both in ICU and across the care continuum.